regard to molecular testing for non-small cell lung cancer now, there are several abnormalities that can be tested for simultaneously. We call that multiplexing. That's very cost-effective. It utilizes the specimen in I think, a completely logical and rational fashion. And it avoids a long delay before getting the information you need to treat the patient. And what I mean by that is if you start just with testing for EGFR, and then if that's negative, then you test for ALK, and if that's negative, then you test for the next abnormality, it takes a long time. More and more also, we have clinical trials for other abnormalities in which extraordinary results are being obtained. And one example of that is KRAS mutation. In the past, in non-small cell lung cancer, we tested for KRAS mainly as a negative test. In other words, if the patient had a KRAS mutation, they were not as likely to respond to a drug like erlotinib. They even were perhaps more resistant to chemotherapy. Now we have classes of agents such as MEK inhibitors, which appear to be very active in KRAS mutation when those MEK inhibitors are given in combination with either chemotherapy or with other targeted agents. Now, none of these agents are commercially available yet, the MEK inhibitors, but they're in clinical trials. And there are enough clinical trials that you can find one of these for your patients. So multiplexing is the way to go. What's the best panel of genes is changing on a month-to-month basis because new things are being added. But in general, a panel is the way to go.